Hello everyone. Today I'm going to be talking about my qualitative study, which is a spin-off study from our large clinical trial. And the title for this study is I Probably Wouldn't Show Up, a qualitative exploration of factors affecting preference for intervention in a preference-based randomized controlled trial of mindfulness-based cancer recovery and Tai Chi Qigong. So as the title suggests, we are running this large clinical trial. It's a comparative effectiveness trial with a preference factor embedded in the randomized control trial. So we allow patients to choose either intervention, the mindfulness-based cancer recovery or Tai Chi Qigong if they have a preference. And if they don't, then they're randomized into either of these two interventions. So this is basically a snapshot of our clinical trial. So we are evaluating the effectiveness of mindfulness-based cancer recovery versus Tai Chi Qigong in cancer survivors. Our primary outcomes are psychological distress. Our other secondary outcomes are physical health factors, physiological factors, and other psychological factors, as well as biological markers as well. So what we really wanted to see in this trial is that whether preference for this intervention actually affects the health outcomes of the clinical trial. So what we've seen in the recent past is basically preference has been found to have a great value in the health outcomes in a clinical trial, as well as in patients' uptake and adherence of the intervention. And if the patients are given their preferred intervention, it leads to better patient outcomes, results in higher uptakes. On the contrary, randomized to a non-preferred intervention may prevent individuals from firstly enrolling in the trials or initiating treatment, and secondly, it also impacts negatively on adherence or recommendations of the trial. So a lot of studies these days are having this embedded component of preference into their RCTs, but a few studies have actually explored the reasons that shape the preference. And this is what our aim was in the study. We wanted to study the factors in a qualitative fashion as to what affects or what shapes the preference for either of these two interventions in this large clinical trial. So our study was qualitative study with a typical qualitative study design. We conducted open-ended semi-structured qualitative interviews. The main questions that we asked in the interviews was patients' reasons for preference, prior experience with intervention, expectations from the preferred program, any concerns regarding the preferred or the non-preferred program. And each interview lasted about 30 to 45 minutes. The interviews were all audio recorded, transcribed verbatim, and then analyzed thematically. So at the end of the interviews, we also administered treatment acceptability and preference measure, which basically assesses participants' perception of the acceptability of the preferred and the non-preferred interventions. So in terms of results, we had a total of 13 people participate in the interviews, of which about 62% had a preference of Tai Chi Qigong and 38% had a preference for mindfulness-based cancer recovery, which is a good reflection of the proportion of preference for TCQ and MBCR in the actual trial. The mean age of our participants was 60 years. Most of them were females, were married, were Caucasians, and were well educated. So these are some of the themes that emerged from the data when we explored the data using thematic analysis. So one of the main reasons for choosing a particular intervention was expectations from the preferred intervention. So if people were seeking relief for their physical health, such as balance or strength, then they preferred Tai Chi and Qigong. Whereas if people were seeking improvement for their mental health, such as relaxation and breathing techniques or distress levels, control the distress, or allow more self-control over the thoughts, that's where they preferred the mindfulness-based cancer recovery. So it was the expectations that influenced their preference. So the next thing was information and evidence. So there were some people who had heard about a particular intervention, so whereas they did not have any information about the other intervention. So it was just easier for them to go with the intervention that they had some information about rather than the other. Similarly, if people had some evidence from informal sources or their family or friends who had done this intervention in the past and were informed about the intervention from their social networks, that also played a role in deciding which intervention the participants want to take up. The next big theme was past experience. So we encountered some patients who had done one of these two interventions like many years ago, maybe 20 years ago, or 10 years ago. And if they had a good experience with the intervention, they decided to go with the same. But if they had a bad experience, a negative experience with the intervention, then that was a deterrent in taking up that intervention. The last but not the least, the major theme was self-efficacy. So participants also factored in their own unique situations into their preference for intervention. So for example, program schedule, whether the class was being held in the morning or in the evening, and what suited their personal circumstances was also a major factor in whether participants went for Tai Chi Qigong or mindfulness-based cancer recovery. And for that matter, I'd like to elaborate that we had programs that were run in the morning and in the evening, and participants were free to choose which class they went for. But towards the end of this program, we had only one evening class for the Tai Chi Qigong, whereas we had both morning and evening classes for mindfulness-based cancer recovery. And these are the results of the treatment and acceptability measure. So as you can see here, we have the results, patient satisfaction or acceptability scores for both the preferred program as well as the non-preferred program. If we look at the Tai Chi Qigong program, we can see here the patient satisfaction scores were higher, the mean scores were higher for the preferred program, and similarly for the mindfulness-based cancer recovery. So regardless of the program patients took, the satisfaction or the acceptability scores were always higher for the preferred program compared to the non-preferred program. So in conclusion, cancer patients perceive benefits of treatment, the information and past evidence, their experience with the treatment in the past, and the treatment schedules are critical in influencing the treatment preference for either mindfulness-based cancer recovery or Tai Chi Qigong for cancer-related distress. And similarly, participants exhibited higher acceptance for their preferred intervention compared to the non-preferred intervention. And we believe that the understanding of these factors will influence